And so a lot of attention is given to the primary endpoint, which is event-free survival, and we think of overall survival as being a key gold standard endpoint. But I want to spend a couple of minutes talking about the pathologic response data. And so, what is the effect of pembrolizumab on a head and neck cancer prior to surgery? And how do you communicate the role of immune therapy to your patients when you give it prior to surgery? Either of you can take that.
Yeah, I mean, I think it's a great question. And, pathologic response, just for those listening, is describing how much effect of the neoadjuvant therapy there is on the tumor at the time of surgery. In other words, how many of the overall tumor cancer cells that were there up front seem to have been eradicated by the neoadjuvant immunotherapy. And that's important to mention because that might be a little bit different than, seeing over those 6 weeks, for example, substantial shrinkage of the tumor. But nonetheless, uh, you know, like John talked about, the improvement in event-free survival, which is the long-term outcome, right? Trying to reduce the risk of patients developing recurrence or dying of cancer is really the aim. So when I talk to patients about it, I tell them very frankly that the goal of this treatment is to activate the immune system against cancer cells. That we've known for some time that immunotherapy helps people with recurrent or metastatic head and neck cancer live longer, and that's been a standard of care for some time. And we now have evidence that when we give these 2 doses of immunotherapy before surgery, that improves the event-free survival, particularly for those folks that have a high PD-L1 marker, which is the marker that we look at that predicts benefit to immunotherapy. And we can really clarify that in more detail when patients come back to see us after surgery. We can actually review the pathologic results, right? How good was the pathologic response? Did we see an effect of immunotherapy against the tumor? And so that's kind of how I contextualize and talk about it with patients.
Yeah, that's great, Ari and John. Anything else that you want
Y-
to add?
Yeah, just to add, when I talk to patients, I don't tell them that I expect that we're going to be changing the surgery that they're going to have. I do tell them that based on what the data shows, it does seem like there's a lower likelihood that they'll need chemoradiation, which is meaningful. Radiation by itself is easier to tolerate. As we're aware, these response rates in terms of the pathologic complete response are quite modest. So I think the real world effect of maybe needing less aggressive adjuvant therapy is meaningful. And I tell them that we can see improvement. I've certainly seen patients have improved symptoms. So we sometimes see a clinical response that can either lag or be greater than or less than the radiographic response. That's why we're not routinely getting scans on these patients before surgery in this short period of time, because as we know from a lot of the neoadjuvant data, scans don't always correlate with the degree of pathologic response.
Yeah, I agree with both of you, and I think we can all agree when we're talking to our patients, the primary role of immune therapy is not to be cytoreductive in the sense of what chemotherapy does and really shrinking the tumor, but it is that stimulation of the immune system and getting that survival benefit, which we've been seeing with Keynote 689. And so I'll add that the data from this trial has resulted in an FDA approval with the treatment of perioperative pembrolizumab as a new standard of care.